Hello everyone, my name is Amanda Casper and I am a graduate student at Eastern Illinois University. The topic I've chosen for my systematic review is maternal diet and how it relates to food allergies in children. My research question and the title of my systematic review is, what impact does maternal diet throughout pregnancy have on the influence of food allergies in children? First, I would like to give a little background into food allergies. I'll summarize the history of food allergies, discuss the recent increase in food allergies, talk about food allergies in K-12 schools, as well as go over terms and tests that are repeated throughout the studies that I used. Food allergies and sensitivities have been recognized as far back as 2700 BC. Writings about individuals with skin lesions after certain foods or urticaria after eating certain foods began to appear in medical books and writings around the 17th century. The first experiment to test food allergies was done by Prausnitz in 1921. Prausnitz took serum from a patient who had a reaction to fish and from a patient who didn't react to fish. He injected both serums into his own skin. The next day, he injected fish extract into the same locations where he injected the serums. A positive reaction occurred in the location where he injected the first serum of the patient who did react negatively to fish. This is now known as the Prausnitz-Küssner test. Despite reactions to foods being recognized and tested, there was still very little public awareness of food sensitivities. Food sensitivities or allergies were less prevalent than they are now, and more clinicians back then were unconvinced that food allergies even existed. From 1997 to 2011, there has been a distinctive rise in the number of food allergy anaphylaxis-related hospitalizations. The reason for this rise is still debated. Previously, medical professionals recommended that pregnant and lactating women avoid known food allergies such as peanuts, tree nuts, eggs, and seafood. Occasionally, women are still given old information and continue to avoid these allergens. From 1997 to 2007, food allergies in children increased 18%. In 1997 to 1999, the prevalence of food allergies in children was 3.4%. This increased to 5.1% in 2009 to 2011. This was about a 50% increase. Additionally, children with food allergies were more likely to have other types of allergies or asthma as well. Food allergies are now much more prevalent and much more researched. The top 8 major allergens are fish, shellfish, egg, soy, dairy, wheat, peanuts, and tree nuts. Other common allergens include sesame, corn, seeds, spices, and some other fruits and vegetables. Most individuals get their food allergies within the first 1 to 2 years of life. The prevalence is approximately 6 to 8% during this time. In late childhood, it drops down to 1 to 2% prevalence. Due to the rise in food allergies, many schools are having to accommodate these new food restrictions. This is done by making some schools completely free of some allergens, such as fish-free schools or peanut-free schools. On a smaller scale, some classrooms will also ban certain allergens, such as peanuts, creating a peanut-free classroom. Within the classroom, some schools have allergen-friendly tables with color-coded trays, plates, or chairs. Products such as sun butter made from sunflower seeds replaces peanut butter in many schools. School cafeterias now have procedures in place to prevent cross-contact in the kitchens, and the staff are all now trained on allergens as well. I will now discuss some of the terms and tests used throughout my studies that I found. Many studies looking into food allergies and allergic reactions in adults and children measure the immunoglobulin E, or IgE. These levels determine whether an allergy is present. Immunoglobulin is a class of proteins found in the serum of the blood and in the cells of the immune systems. They are our antibodies. Antibodies protect against a specific antigen. The antigen is a toxic or foreign body that the antibody believes is harmful to us. The antibody attacking the antigen elicits an immune response. Immunoglobulin E is the fifth type of immunoglobulin recognized in our immune system. It was not recognized by the World Health Organization until 1968, so it is a more recent discovery. IgE was discovered specifically because of how it reacts to certain allergies. People who react to allergens produce IgE specifics to the allergen. The primary role of this IgE was to protect the human body against parasites. However, since there are very few parasites in the United States, the IgE has evolved to function as something else. The skin prick test, or the Prausnitz-Küssner test mentioned at the beginning of this presentation, is where the allergen or antigen of the allergen is put underneath the skin, the surface of the skin. The IgE will react with the antigen and cause a small reaction or a wheal. The diameter of the wheal determines if the test is positive or not. Lastly, the oral food challenge test is done in a medical setting, such as a clinic or a hospital. The suspected allergen is eaten slowly, while also slowly increasing the amount of the allergen consumed to determine if an allergic reaction occurs. This is usually only done when the skin prick test and IgE blood serum tests are inconclusive. The purpose of the study is to determine the influence of maternal diet on food allergies in children. Next, I'll discuss how I retrieved my articles. I used the Prisma method to retrieve all of my articles. I used three databases, the EIU Booth Library Database, PubMed, and CNOL. I found a total of 1,464 journal articles using the keywords food allergies, maternal diet, pregnancy, egg, wheat, peanut, and dairy. After removing all the articles not published between 2009 and 2019, 698 articles were left. Duplicate articles removed and titles and abstracts were scanned for relation to the purpose statement. The abstracts of the remaining articles were reviewed to determine if they met the remaining criteria. Articles were excluded if they were not an experimental study, if the full text was not available, and if the articles were not in English. 10 articles remained for the systematic review. The first study that I found was published in 2015 in the Journal of Allergy and Clinical Immunology by Bunjevanic et al. Is titled Peanut, Milk, and Wheat Intake During Pregnancy is Associated with Reduced Allergy and Asthma in Children. This study was done in Massachusetts as a longitudinal cohort study. Initially, 2,128 mothers were chosen to participate. Each mother was given a 166-item semi-quantitative food frequency questionnaire modified for pregnancy. The total number of servings per day for peanuts, milk, wheat, eggs, and soy were calculated. The food frequency questionnaire was given at 10 weeks gestation and then at 26 to 28 weeks gestation. A follow-up on the child's outcome was sent at 6 months after birth, 1 year after birth, and once per every year until the child reached mid-childhood, which was an average age of 7.9 years. Questions to determine asthma, allergic rhinitis, and atopic dermatitis were taken from the International Study of Asthma in Childhood. Many of the studies also study asthma, allergic rhinitis, and atopic dermatitis along with food allergies, because if a child has one, they are more likely to have the other. A child was considered to have a food allergy to peanut, milk, wheat, egg, and/or soy if the child had a specific IgE level greater than 0.35 Ku per liter to the particular food, and an EpiPen was also prescribed. The unit Ku per liter, or International Units per Milliliter, was created to express the levels of IgE in peripheral blood, since very low levels of serum IgE can be hard to express. 1 Ku per liter is equal to 2.4 nanograms per milliliter. This level was determined by drawing blood. Of the 1,277 mother-child pairs that responded at mid-childhood, 702 agreed to have their blood drawn. Of the 702, 87.7% of children, or 616 of the 702, had a sufficient enough serum sample to measure allergen-specific IgE. However, for a peanut allergy, questions answered by the mother were used to determine an allergy. Answering yes to "Has your child ever had a reaction to peanuts?" with at least one of the related symptoms: skin-related reaction, respiratory reaction, cardiovascular reaction, gastrointestinal reaction, or anaphylaxis. Of the 616 participants whose IgE levels were tested, milk was the most prevalent food sensitivity, followed by peanut, and peanut was the most prevalent food allergy. Most children who were sensitive to at least one allergen were also sensitive to at least one other allergen. An additional cross-sectional study was done within this study: the association between food allergy, asthma, and atopic conditions. Milk allergy was associated with an increased odds of the child having asthma. The second study found was published in 2010 in the Journal of Investigational Allergology and Clinical Immunology by DeRoche et al. It was titled "Peanut Allergy: Is Maternal Transmission of Antigens During Pregnancy and Breastfeeding a Risk Factor?" This study was conducted in Montreal, Canada. Participants and control participants were recruited from a pediatric university center in Montreal, Canada from 1998 to 2004. Infants aged 18 months or younger and presented a peanut allergy at an outpatient clinic were recruited. Peanut allergy was defined as a previous clinical reaction within 60 minutes of exposure to peanuts, as well as peanut-specific IgE, or immunoglobulin E, which can be found by either the skin prick test or serum IgE levels. A reaction was considered a clinical reaction if one or more symptoms were present. The symptoms were skin reactions, respiratory reactions, or gastrointestinal reactions. Food challenges were not done due to the age of the participants. 248 infants were recruited to be case participants. Of the 248, 36 infants were excluded because they had a negative skin prick test to peanuts, and 2 were excluded because their mothers did not speak French and could not communicate with the researchers. This left 210 eligible infants, of which 202 chose to participate. The control infants were of the same age and recruited from the same location. However, they did not present with any form of allergic reactions to anything. 410 infants were initially recruited. 195 were excluded because they showed signs of atopic reactions such as eczema or chronic rhinitis, and the mother was not present at the clinic, or the mother did not speak French. Of the 215 eligible infants, 201 control participants participated. This gave the researchers 403 total participants. A food frequency questionnaire was given to the mothers at the clinic that questioned their diet throughout pregnancy and breastfeeding. They were asked whether they had eaten certain foods once a day or more, 5 to 6 times a week, 2 to 4 times per week, once per week, 1 to 3 times per month, or never. In the case of peanut butter, they were also asked to record the portion consumed. The food history of the infant since birth was also reported by the mother, and the presence or absence of peanuts in the environment were also recorded. Peanut consumption during pregnancy and breastfeeding was higher in the case group. Additionally, peanut atopy in mothers was higher in the case group as well. Breastfeeding and peanut allergy showed no significant results, however. The third study I used, prospective study of per-pregnancy consumption of peanuts or tree nuts by mothers and the risk of peanut or tree nut allergy in their offspring, was published in JAMA Pediatrics in 2014 by Frazier, Camargo Jr., and Malspice. In 1989, the Nurses' Health Study 2 began. This study was completed in the United States. 116,430 nurses aged 24 to 44 years responded to a questionnaire that included lifestyle and medical history. Dietary data was collected in 1991 using a semi-quantitative food frequency questionnaire. The nurses reported usual intake of peanuts, other nuts, and peanut butter using 9 categories ranging from never to 6 or more times per day. In 2004, a baseline questionnaire was sent to all of the offspring of the Nurses' Health Study 2 between the ages of 10 to 14 years. This was the beginning of the Growing Up Today Study 2, or GUTS 2. This cohort provided information on lifestyle and medical history on a questionnaire every 2 years, beginning in 2004. In 2009, a food allergy questionnaire was sent to the mother of every child in the 2004 GUTS 2 cohort, which was approximately 10,907 mothers. The questionnaire asked if the child had a food allergy, and if yes, to what they were allergic to, including peanuts, tree nuts, shellfish, milk, eggs, or other. The questionnaire also asked about exposure to allergens, including the mother's personal history of food allergy. 523 children reported in the 2006 GUTS 2 study that they had a food allergy. These mothers received an additional questionnaire asking to report the dermatologic, respiratory, cardiovascular, and/or gastrointestinal symptoms associated with the child's food allergy. 466 mothers returned the questionnaire. If their children had not completed the 2006 survey or they did not report a food allergy in the 2006 GUTS 2 survey, but the mother reported a food allergy on the 2009 survey, the mother was sent another questionnaire. An additional 325 cases of food allergy were reported between the 2006 survey and the 2009 questionnaire. Overall, 733 GUTS 2 participants' mothers returned the questionnaire to confirm diagnosis. Of these 733, 233 mothers disagreed with the allergy diagnosis, the most common reason being milk allergy versus lactose intolerance. Allergy was confirmed or denied by the participant's physician and agreed upon by the participant's mother. Overall, there were 8,205 participating children in this study, 140 of which presented a peanut or tree nut allergy. Children whose mothers reported the highest consumption of peanut and tree nut throughout pregnancy and were not allergic to peanuts or tree nuts themselves had the lowest risk of peanut or tree nut allergy, P equals 0.4. Increasing maternal consumption of peanut and tree nut lowered the risk of peanut or tree nut allergy in children throughout all categories, P equals 0.004. The lower risk of peanut and tree nut allergy was not observed in children whose mothers had a peanut or tree nut allergy. Mothers who presented with a peanut or tree nut allergy were more likely to increase the risk of peanut or tree nut allergy in offspring with increased consumption of peanut and tree nut, though the results were not significant. The fourth study that I found was my first rodent study. It was published in 2015 by Jarvinen et al. In PLOS 1. The article is titled Role of Maternal Dietary Peanut Exposure in Development of Food Allergy and Oral Tolerance. This was a rodent study done in the United States. 6-week-old female and male mice were purchased from Maine, and female mice were purchased from New York. The female mice purchased from New York were approximately 5 to 8 weeks old. Female mice from Maine were gavage-fed ground peanut at 10 milligrams per mouse. Gavage feeding is feeding directly into the stomach, either via syringe or tube. The peanut was turned into liquid form and put directly into this mouse's stomach via needle. They were fed this ground peanut 3 times a week for 4 weeks before conception. Blood was collected at week 5 to determine immunoglobulin levels. Afterwards, they were mated with the purchased males. The preconceptionally peanut-exposed mothers were split into 2 groups through pregnancy and lactation. One group was continually gavage-fed peanut 3 times a week throughout pregnancy and lactation. The second group was fed regular mouse chow, which did not contain peanut. Mothers who were gavage-fed ground peanut were also given peanuts to ingest as they wished. Mice who were not preconceptionally fed peanuts were used as a control. The offspring had blood drawn at week 5 of life and week 15 of life, and peanut-specific IgE, IgG1, IgG2A, and IgA were measured using ELISA. 2 weeks after the last booster, offspring were given 100 milligrams of peanut, followed by an injection into the abdominal cavity of 100 micrograms after 30 minutes. Anaphylactic signs were recorded. While antibodies were transferred to the offspring during pregnancy and lactation, there did not seem to be any correlation between peanut exposure and immune status in offspring. However, offspring could increase tolerance to peanuts if directly fed peanuts after weaning. The 5th study that I found was also a rodent study done in the United States. It was published in 2010 in the Journal of Allergy and Clinical Immunology by Lopez Exposito et al. The study is titled Maternal Peanut Exposure During Pregnancy and Lactation Reduces Peanut Allergy Risk in Offspring. 6-week-old female and male mice were purchased from the same facility in Maine that the previous study purchased their mice from. They were fed a peanut-free diet. The purpose of this experiment was to determine whether peanut allergy in mothers affected their offspring's reaction to the first peanut exposure. Freshly ground peanut was used as an antigen. The methods for the experiment were taken from a previous experiment where maternal mice were given 10 milligrams of peanut per week, then received a 6-week booster of 50 milligrams of peanut, and an additional booster of 50 milligrams of peanut at 8 weeks. For this experiment, researchers skipped the 8-week booster to prevent anaphylaxis in the peanut allergy mothers. The females were then mated with the males. During pregnancy and lactation, the mice ate normal mouse food free of peanuts. Naive mice were used as controls, never given peanuts. Offspring of the peanut allergy mice were weaned at 3.5 to 4 weeks. At 5 weeks, the offspring were given 200 milligrams of peanut per mouse. The first round of experiments, a majority of the offspring developed severe near-fatal reactions, making blood collection from them very difficult. Therefore, in subsequent experiments, the 6-week 50 milligram booster to the mother was not given. All offspring of the peanut allergen mothers had recorded anaphylactic symptoms when first exposed to peanut. No control offspring reacted to peanut exposure. However, low doses of peanut to peanut allergen mothers during pregnancy and lactation lowered the risk of anaphylactic reaction at first peanut exposure in offspring. Study number 6 by Nuaru et al. Was published in Pediatric Allergy and Immunology in 2010. The article is titled Maternal Diet During Pregnancy and Allergic Sensitization in the Offspring by 5 years of age, a prospective cohort study. The study examined the effect of maternal diet during pregnancy on allergic sensitization in offspring at 5 years. This study was completed in Finland using mother-child pairs that were enrolled in the Finnish Type 1 Diabetes Prediction and Prevention, or DIP, nutrition study. This study began in 1994 and is an ongoing study exploring the possibility of preventing type 1 diabetes. All newborn infants with the human leukocyte antigen, or HLA, susceptible to type 1 diabetes were recruited for this study. Between 1998 and 2000, 1,175 consecutively born children were requested to participate in the allergen study at the age of 5 years. 1,067 of these individuals participated in the study. Serum IgE measurements were performed in 1,018 participants. Of the 1,018 children, 78 only have serum IgE levels, while 940 individuals also had a maternal food frequency questionnaire from pregnancy. 9 individuals from the 940 were excluded from the study due to an incomplete food frequency questionnaire, giving 931 participants with food frequency questionnaire during pregnancy and serum IgE levels. The food frequency questionnaire was an 181 item that was used to determine maternal intake during the 8th month of pregnancy and dietary supplement use during the whole gestation period. Mothers received the questionnaire after delivery and returned it at the child's 3-month visit. IgE levels were taken from children at 5 years. Total sensitization was measured at 100 Ku per liter, and specific IgE levels were measured at greater than or equal to 0.35 Kus per liter. Specific IgE that was tested was egg, cow's milk, fish, wheat, house dust mites, cat, timothy grass, and birch. Inhalant allergic sensitization was more common than food allergen sensitization. The most common sensitized food allergen was cow's milk. Increasing maternal intake of vitamin D was associated with decreased sensitization to food allergens. Additionally, increased fruit and citrus fruit was associated with allergic sensitization against inhalants. The 7th study that I found and used was done in Brittany, France by Pelle et al. It is a prospective cohort study published in a journal called Environmental Health in 2013. The title of this article is Maternal Fish and Shellfish Consumption and Wheeze, Eczema, and Food Allergy at Age 2, a prospective cohort study in Brittany, France. A cohort of pregnant women living in Brittany were recruited to participate in this study. The goal of the study was to determine if there was an association between fish and shellfish intake during pregnancy on wheeze, eczema, and food allergies. 3,421 pregnant women were recruited for this study before 19 weeks gestation from 2002 to 2006. Women received a questionnaire regarding their family, social and demographic characteristics, as well as diet and lifestyle. These women gave birth to 2,232 live-born singletons who were eligible for follow-up at 2 years old. 2,996 questionnaires were sent to mothers around the children's second birthdays. Families that were excluded from the study included 6 children who passed before their second birthday and 1 mother who passed before the child's second birthday, in addition to 320 children who were already older than 2.5 years. Of the 1,996, 770 could not be reached. 2,226 mothers received questionnaires and 1,505 mothers returned the completed questionnaires. 1,500 mothers had fish and shellfish data available. Seafood consumption was evaluated in 4 categories: saltwater fish, mollusks, large crustaceans, and small crustaceans. Wheeze was identified through 5 different questions. Eczema was identified through 2 questions, and the presence of food allergies was identified by a yes answer to 1 of 3 questions. The 3 questions for food allergies are: has your child had a medical diagnosis of cow's milk allergy? Has your child ever had a diagnosis of any food allergy? Or has your child ever had an allergic reaction after eating food? 1,487 children made known their food allergy status. 136 children had a food allergy. 37 children were diagnosed with a cow's milk allergy. 41 had a medical diagnosis of general food allergy, and 22 had both a food allergy and a cow's milk allergy. 36 children had allergic reactions to food, but no medical diagnosis. Shellfish intake of once a month or more was associated with an increased risk of food allergies. When fish was included with shellfish, the association decreased slightly. There was no association between fish intake and food allergens. The 8th study that I found was published in the Journal of Allergy and Clinical Immunology in 2010. It's titled "Maternal Consumption of Peanut During Pregnancy is Associated with Peanut Sensitization in Atopic Infants," and written by Sashir et al. In the United Kingdom, from 1998 to 2000, the Committee on Toxicology, as well as the American Academy of Pediatrics, recommended that mothers at risk for allergic reactions avoid peanuts throughout their pregnancies. In 2008, the American Academy of Pediatrics reversed their position and stated that avoiding or increasing consumption of peanuts had no effect. 512 infants enrolled in this study at an average of 9.5 months at 5 different locations in New York, North Carolina, Maryland, Colorado, and Arkansas. The children were enrolled if they had previously had a reaction to or been diagnosed with an egg or milk allergy and were at risk for developing a peanut allergy but did not currently have a peanut allergy diagnosis. 308 children reacted to cow's milk or egg immediately, and 204 had a moderate skin reaction to cow's milk or egg. Mothers completed questionnaires on their ingestion of peanuts throughout each pregnancy trimester and breastfeeding as either avoided, ingested less than 2 times per week, more than 2 times per week but less than daily, or unknown. Peanut ingestion during the 3rd trimester was selected for data because it was most likely to be unbiased. The infants were given skin prick tests to standard allergens, which were egg, milk, peanut, dust mites, mold, and cockroach. A positive skin prick test was defined as a wheal diameter greater than 3 millimeters. Specific IgE antibodies were tested for egg, milk, and peanut. A level greater than 0.35 Ku per liter was considered positive. 53.7% of children, approximately 270 children, had a positive skin prick test to peanuts. 60.6% had positive IgE levels for a peanut allergy, and 346 participants, or 68.8%, had sensitization detected by at least one test method. Increased peanut IgE levels were significantly associated with milk and egg IgE levels, meaning that children with milk or egg allergies were more likely to be sensitized to peanuts. Study 9, titled Maternal Dietary Folate, Folic Acid, and Vitamin D Intakes During Pregnancy and Lactation and the Risk of Cow's Milk Allergy in the Offspring, was published in 2016 in the British Journal of Nutrition by Tuokola et al. Study number 6, the Finnish Type 1 Diabetes Prediction and Prevention Study, or DIP, was the basis for this current study. 6,288 children born between 1997 and 2004 were recruited for this study. Mothers of 4,921 children responded to the study by providing dietary data from 4,851 pregnancies. Mothers completed a 181-item food frequency questionnaire regarding their diet in the 8th month of pregnancy and returned the questionnaire at the child's 3-month checkup. The same food frequency questionnaire from study number 6 was used. To determine whether children had a cow's milk allergy, researchers received information from a register maintained by the Social Insurance Institution that listed children that had a physician-diagnosed cow's milk allergy. The study found that mothers that consumed folic acid supplements or vitamin D supplements increased their child's risk of cow's milk allergy. High maternal intake of folate increased the child's risk of cow's milk allergy, while maternal intake of vitamin D from food seemed to decrease the risk of cow's milk allergy. However, taking both vitamin D and folic acid at the same time showed an increased risk of cow's milk allergy. The final study that I found was published by Venter et al. In 2009 in the Pediatric Allergy and Immunology Journal. It is titled Factors Associated with Maternal Dietary Intake, Feeding and Weaning Practices, and the Development of Food Hypersensitivity in the Infant. All pregnant mothers with a delivery date between 2001 and 2002 were approached at a prenatal clinic to participate in the study. Mothers who chose to participate, about 996 women, relayed information on their family history of allergens, smoking, social class, and pets through a questionnaire. At 36 weeks gestation, mothers filled out a food frequency questionnaire. Another questionnaire regarding feeding practices, immunization status, and symptoms of atopy were obtained via questionnaire at the child's 3, 6, and 9 months, as well as 1, 2, and 3 years. Children who showed a reaction to a food were invited to an allergy center to determine what foods caused the reaction. Information on initial reaction was taken from the parents. Children were also skin prick tested to the suspected food at the time of their initial visit to the allergen center. Additionally, they were skin prick tested at 1, 2, and 3 years to a panel of allergens including milk, egg, wheat, cod, peanut, and sesame. A wheal larger than 3 millimeters was considered a positive skin prick test. Food challenges were conducted with all foods from 6 months old except for peanut and sesame, which was held off until the children were at least 3. Children excluded from the food challenges presented with a positive skin prick test. At 1 year, 17 children were sensitized to any of the tested foods, and 39 children were diagnosed with food hypersensitivity. At 3 years, 23 children were sensitized to any of the foods tested, and 58 children were diagnosed with food hypersensitivity based on open food challenges and a positive skin prick test. It did not appear that maternal diet throughout pregnancy affected food sensitization or food hypersensitivity in offspring. Some of the limitations of these studies, some of the studies were observational studies where the mothers filled out a food frequency questionnaire after their children's birth. Additionally, the food frequency questionnaire answers could have been biased if the mothers knew what the researchers were looking for. In some studies, the children's allergies, even though diagnosed by a medical professional, were self-reported by the parents. 3 studies did not differentiate results between pregnancy intake and intake during breastfeeding, so the results were combined. The food frequency questionnaires were very detailed. However, long questionnaires can often tire participants who, towards the end, no longer answer honestly. Overall, 4 studies showed reduced risk of food sensitization, food hypersensitivity, or food allergens. 3 studies showed increased risk of food sensitization, food hypersensitivity, or food allergens, and 2 studies showed no correlation between maternal consumption and food reactions in children. 1 study showed an increased risk of food reaction, though the results were not statistically significant or clinically significant. The results were inconclusive as to whether or not maternal diet influenced food allergies in children at all. Additionally, 2 of the studies found that it is more likely that if the mother has a peanut or tree nut allergy and avoids that allergen, then the offspring will also have that allergen. Implications for professionals. Previously, it was recommended that mothers avoid certain allergens, particularly peanuts and fish, while pregnant to avoid allergies in children. This has since been revoked, and there is currently no recommendation on whether mothers should or should not avoid certain allergens. Some professionals are recommending to eat more of some allergens to help prevent a food allergy in children. As professionals, we can use this information to help guide pregnant clients who are concerned about their children having food allergies. The implications of future research. Researchers can have mothers keep a food diary for each trimester or study 1 trimester at a time using a food diary to ensure that allergens consumed were more accurate than a food frequency questionnaire. This can also help prevent bias as some of the food frequency questionnaires may have incurred. The next few slides are the references used. Thank you for watching my presentation.